Hi, I'm Greg Okrentz. I'm a general internist at the White River Junction VA and on faculty at the Geisel School of Medicine at Dartmouth. And this screencast will give you an introduction overview of the tools and extensions of the SQUIRE guidelines. As a reminder, the SQUIRE guidelines are the standards for quality improvement reporting excellence. They were developed and published in 2008 and are available to help you prepare and publish your quality improvement work. So since that time of publication, how has SQUIRE been used? Well, the most basic, of course, is for written articles. That is certainly what they were intended for and what they are often used for. They've been used for abstracts and posters. The IHI Scientific Symposium, QI Research Symposium, and the BMJ International Forum on Quality both use SQUIRE as the framework for their submitted abstracts. QI department has used them for an annual report, and we have done some work using them to differentiate between QI and research, often a thorny issue and a difficult issue for those of us who work in quality improvement and our interactions with our institutional review boards and our ethics review boards. So we're going to focus on this last bullet point for the remainder of this screencast. So how might we address this question of QI versus research? In 2006, there was a clear framework for quality improvement was proposed, and one of their recommendations was a recommendation for independent review of QI. Now, we know that institutional review boards, ethics review boards, do not always understand the intent, the methods, and the analysis of QI work. Many IRBs have trouble with this. They are just not familiar with QI work. And particularly, they have trouble with identifying what is quality improvement and then clearly delineating it from research. So we thought SQUIRE might be able to help with this. We set out to develop a practical instrument for institutional review boards, researchers, and improvers to differentiate between QI and clinical research activities. And this was our aim. We worked on this from spring of 2009 through spring of 2012, starting with an expert panel and work with our institutional review board director here at Dartmouth College. We had face-to-face and asynchronous meetings together, and what we developed eventually was an instrument that we then used prospectively with submissions to the institutional review board at Dartmouth. So let me give you an overview of what this instrument looks like. This is part one of the instrument. Now, there are 4 overarching questions that precede this part of the instrument. These 4 questions deal with the risk of vulnerable situations, the inherent risk to the population, and those components are important for you to answer up front. And those questions, those 4 overarching questions, are available in this journal article here from 2013. So the reference here is for you to look at it. The table is split into 3 columns. There is a column that lists the attributes, the components of quality improvement, and this column is taken from the SQUIRE guidelines. And then there's a column about clinical research with human subjects. There are 6 attributes total in the instrument, and so we see 2 of the attributes here, intent and background and methods. And so, as you see, and what we think the advantage of this instrument is that it clearly defines what is part of quality improvement. So it's not making quality improvement just things that are not research. It's telling you the clear components of what goes into quality improvement. So quality improvement tends to describe the nature and severity of a local performance gap, and it's focuses on improving a specific aspect of healthcare delivery that is currently not consistently and appropriately being implemented. Clinical research, as we know, really focuses on developing new knowledge or advancing existing knowledge, and the information in this column for clinical research with human subjects are taken from the U.S. federal definition of clinical research with human subjects. Methods is really one of those places where QI is very distinct. The methods of the intervention expect to change over time. It's an iterative activity, and the analysis includes assessment of the system, and statistical methods evaluate system-level processes. In general, with clinical research, you have a specific protocol for collecting data, qualitative or quantitative methods to make observations or comparisons during group, and the statistical methods primarily compare differences between groups or correlate observed differences with a known condition. If we look at the part 2 of this, you see the attributes of intended benefit and risk. So in quality improvement, the intervention is often considered within the usual clinician-patient therapeutic relationship. Quality improvement work is much closer to that individual clinician-patient work where you're trying to improve care for patients, whereas research is often thought to be outside the usual clinician-patient therapeutic relationship. Often a direct benefit to participants is indicated, and there may or may not be direct benefit for participants in research work, whereas there is a societal benefit of developing new knowledge, and you also often see an institutional benefit for QI work. Primary risk in QI is to confidentiality of health information, and you could even make the case that risk might be higher for patients who do not participate in QI work. Perhaps they'd have less of an opportunity to receive an important vaccination or to have a timely intervention done for something as a heart attack. Risks can be minimal in research, but they can include a range of categories. And the informed consent process is a key component for research, and that is really important to protect participants in research studies. The last 2 sections are the applicability of results and the sharing and disseminating of results. The applicability of results in QI work is really important. Its implementation is immediate, and the results occur throughout the process, and they're used to build into the next QI activity. And in clinical research, results are often delayed or periodic, and they're often used to perform and inform further investigations. You don't always extrapolate to other settings, but it might occur, and the results in research are certainly intended to generalize beyond the study population, and therefore it's expected that results will be published or presented to others through peer review process. In quality improvement, and this is what I think is very different now, system-level outcomes, processes, changes to the intervention, applicability of the intervention in specific settings and contexts may be shared, and I would actually say I would encourage to be shared through peer review publication and presentation, both inside and certainly outside the institution. This tool is not intended as an absolute adjudicator. It is a tool to help with conversations. When you look at the 6 attributes for clinical research, if you get even 1 check mark in one of these boxes, then we would recommend that the proposal be reviewed with your institutional review board or ethics review board, because even 1 check mark over here would mean that there is a significant component of research in the proposal. This is intended to make discussions about QI and research more focused and concrete, and to help improvers and researchers and IRBs and organizations have those conversations and have meaningful and focused conversations about this distinction.